Hello. Hi, my name is Chopra. I'm an assistant professor, pain medicine specialist at the Brown Medical School. And I'm here to talk about management of chronic pain in Ehlers-Danlos syndromes. I'm going to touch briefly on different aspects and the principle behind treating or managing pain in patients with Ehlers-Danlos syndromes. This is my standard disclosure and disclaimer. I have no actual or potential conflict of interest in relation to this presentation or program. There will be some discussion of off-label use of medications. Discussions in this presentation are just for general information purposes. As part of my disclosure, I am a pain medicine specialist with a special interest in complex pain conditions. My training was at the Howard Medical School. I now work as an assistant professor at the Brown Medical School in Rhode Island, USA. I'm also on the medical board of a couple of charitable nonprofit organizations, one of them being the Coalition Against Pediatric Pain. I have no specific financial disclosures at this time. Now, one of the things about the management of chronic pain in Ehlers-Danlos syndrome is we're in uncharted territory. The discussion in this presentation was being taken from multiple specialties at sources. What I did was I looked at pain medicine, I looked at rehab medicine, orthopedics, neurology, cardiology, immunology, and of course, a lot of it was from my patients, seeing my patients with Ehlers-Danlos syndromes come in and what worked, what didn't work over the years. So what are the basic principles of treatment of chronic pain in any condition for that matter? There's no cure or there's no one magic treatment or one magic pill that treats chronic pain. We have to understand chronic pain is a symptom. It's not a disease by itself. It's a symptom. If someone has heart disease, is having an angina, the cure is not to give them a painkiller, but the cure would be to actually treat their angina. So managing pain is about finding the pain generator, like what's broken, what's hurting. And then of course, not everything can be fixed. There are very few things in medicine actually that we cure. Most of it is we manage. We don't cure hypertension or we don't cure diabetes mellitus. Same thing with chronic pain conditions. We don't cure them, we manage them. But the goal, so one has to set up goals, and usually the goal is about 50% pain control and to be more functional. Also as we see more good days than bad days. So the question is, in order to manage patients with chronic pain, it is crucial to understand what's the cause of the pain. For example, in Ehlers-Danlos syndrome, a patient coming in with pain in the shoulder, it could be from a dislocated joint, it could be a rotator cuff tear or a fracture, muscle spasms, or a nerve or a blood vessel impingement or damage, and it could be all of those or some of those. So the treatment would vary depending on which is a more presenting condition here. So finding out what's the problem is fixing it. By just giving this patient a painkiller or a pain pill or giving them NSAIDs or is not going to make the difference. The difference is to find out, okay, if there's a dislocated shoulder or if there's a subluxed shoulder, let's put that back and stabilize it. So the principles of managing pain in Ehlers-Danlos syndrome is to use a mix of treatments. I call it the 10% rule. So if you can get 10% out of one therapy, for example, let's say physical therapy helps out 10%, and let's say stabilizing the joint helps out 10%, NSAID helps 10%, so on and so forth. If you get 5 of these 10%, you wound up with getting 50%, and that was our goal. So just to give you an example, if someone comes in with knee pain and it's because of a knee joint instability, the trick would be to, okay, let's stabilize the knee with braces, and then let's start strengthening these muscles around the knee, and maybe try medications at the same time, whether they are topical or PO or injectable, whichever. So the general concepts of managing pain in Ehlers-Danlos syndromes is there are three things to know. The first thing is that we know that these patients have a weak connective tissue. Their collagen is weak. It's stretchy. It breaks easily. When it breaks easily, it doesn't heal as well. They have poor joint position sense, also known as proprioception. And a vast majority of these patients have coexisting medical conditions, like dysautonomia or mast cell activation syndrome. I will not be going into great detail about dysautonomia and mast cell activation syndrome because I believe that there will be experts and specialists who will talk about that. But I'll briefly touch upon it because that contributes to what I call as the non-functionality of these patients, contributes to the pain in these patients. So briefly, there are two types of tissue injuries in patients with Ehlers-Danlos syndrome. There's the macro trauma, where there's a large event or a trauma resulting in injury. So it's pretty obvious. This is a dislocation, the shoulder joint is dislocated, or there's a fracture, a broken bone. And these events are far and few, and these are not as disabling, believe it or not. Dislocations, most patients with Ehlers-Danlos syndrome actually can manage their subluxation dislocations fairly well. Obviously, the fracture is a different story. But on a daily basis, what really bothers these patients is the micro trauma. These are small repetitive traumas that are invisible to us. They result in constant tissue breakdown. And like I said, the tissue is not strong. It's very weak. It takes a while to heal. And when it does heal, it doesn't heal well. And oftentimes, microtrauma is from things like overstretching their muscles and ligaments, doing repetitive motions like vacuuming, chopping food, dusting. And so and that's the reason why I put down microtrauma in red, is because that is far more disabling and affects their lifestyles more than a macro trauma. This is just to show you a picture of what a macro trauma would be. And over here, you can see, pretty obvious. There's dislocated joints over here. There's a broken bone here. There's no rocket science behind this. But the issue is that a lot of these patients have what is called microtrauma. They have small tears and damages in their ligaments, ending up in tendinitis, bursitis, and that is what disables these patients the most. My other thing was about joint position sense. These patients have a poor joint position sense, also known as proprioception. The presentation is often, they'll tell you that they are very clumsy, they fall a lot, they trip a lot, they drop things a lot, they trip over while walking up the stairs, and that is poor proprioception. I'll explain that to you again. Over here, you can see what happens is when we have sensors in all our joints. Every single joint, tendon, muscles have sensors, and these sensors send feedback to the central nervous system. And then the central nervous system in turn sends signals to other parts of the body, and they act upon it to maintain a balance and prevent joints from being hyperextended. They maintain balance. They protect us as we walk. This information that the brain gets, it helps us be able to be more stable as we move. The problem in Ehlers-Danlos syndrome is that they have poor proprioception. One can see poor proprioception physiologically in the toddlers, for example. Oftentimes when toddlers first learn to walk, they fall a lot. It's because they still haven't developed their proprioception. Oftentimes the elderly fall a lot is because they have poor proprioception. Their joints are worn out. They have arthritic limbs. Their muscles are weak. And so they have poor proprioception. And that poor proprioception is the reason why they fall a lot. These are some of the exercises that one can use. They're pretty straightforward, actually. They're really simple. They're more like balance exercises using the balance board or a wobble board. Stoke standing is you stand on one leg. Generally, I'll ask them to practice standing on one leg with their eyes open and touching something or touching a stable object. And then I'll have them stand with their eyes closed. And then I'll go a step further and say, okay, stand on one leg without touching anything. Sitting on an exercise ball, and of course the best one is exercise in water, which I'll discuss a little in detail down the line. So one of the tricks is that the brain, when it's not getting any feedback or senses from the sensation from the joints and tendons, it uses contact with skin to understand the position of the joints and muscles. It makes sense to wear compression clothes, not very tight, but just light enough, what I call it skin tight. And what the brain does is it uses that to understand the position of our body parts and muscles. Hence, you'll see why one of the reasons why athletes prefer wearing skin-tight clothes is because it helps them with their joint position and, of course, prevents breakdown in their joints. And then aquatherapy is, again, water in contact with the body, gives them a sense of their joint position or spatial sense. This is a sample of compression garments. It can be either full length covering the hip joint, the knee joint, all the way down, or it can just be localized to the knee joint. And one can buy these commonly at any sports store or online. Literally, there are compression garments for every joint. A little note on subluxations and dislocations, what they mean and what's the clinical significance. A dislocation is when actually the capsule tear, there's a capsular tear, and the bone actually moves out. And in these patients, they dislocate the bone is out of position. Some of the more veteran EDSs, as I call them, will be able to, they know how to push it back in place. But it is a far more painful condition. What's more common is actually subluxations, in which there's a stretching of the capsule. So the bone doesn't really lose its position as much. It's just very loosely it's loose around the joint. And most patients with EDS present with subluxations far more than they present with dislocation. Clinically, one can when you ask them, they'll tell you, yeah, I feel this pop and it's really uncomfortable, and then I do something to it, and then all of a sudden it goes back in place. Something goes back in place, and I feel much more comfortable. This is to differentiate from cracking your knuckle type. That's a different sensation. But oftentimes they'll say it's very uncomfortable, and then they shift their joints around, they shift their limb around, and then everything goes back in place, and they feel a lot better. But here's the thing. When a joint subluxes or dislocates, the pain is from the muscles that surround the joint. So there are muscles around every joint, and these muscles go into a spasm, and that's where a lot of this pain comes from. They also have pain from the capsular stretch and the ligament stretch, but it's not as much from the bones themselves. So if one is to look at these patients with, say, like, if they have a muscle spasm around the joint, is that because they are subluxing the joint a lot more? So treating the muscle may not be a good idea in these cases, because in that case, they'll just sublux a lot more. So this is to give you an example. So the shoulder, you can see the muscles around the shoulder. This is part of the rotator cuff group. And you can see if this shoulder joint were to dislocate or sublux, then these rotator cuff muscle groups would be stretched, and they would go into a spasm, and as a result, this patient is going to present with pain over the upper back and into the anterior shoulder joint. This is another example, back pain. The spine is made up of pairs of joints on both. There's a pair of joints across the spine, all along from the cervical to the thoracic to the lumbar region, and then you have the sacroiliac joints over here. Now, they can present with subluxations of any of these joints or most of these joints. What happens is that these big muscle groups start to spasm up, and they may end up with presenting with pain. The point I'm trying to make over here is that even though it looks like a muscle spasm pain, it's going in there and doing a trigger point injection or trying to give them a muscle relaxant to loosen up the muscle may not be a good idea, because in that case, we are promoting their subluxations even more. They're likely to sublux even more. So you get into this vicious cycle. the treatment would be ideally to stabilize the joints. So this is the mainstay of treatment of chronic pain and Ehlers-Danlos syndrome is exercise. It's a tough call in these patients because they also present with an immense amount of fatigue, and we'll talk about that a little later. So we have to find this balance between fatigue and being able to exercise. So the trick is to strengthen the muscles without stressing the joints. We want to strengthen these muscles because we want to stabilize the joints. We also want to do proprioception exercises so that we can protect these joints. The key point over here is to exercise consistently rather than the degree of exercise. I rather they do 1 pound, 10 reps a day than do 20 pounds and 5 reps 3 days a week. So there's a big difference in that. It has to be done very consistently in these patients, almost literally on a daily basis. If they feel exhausted, if they feel tired, and look, I was having a bad day, I had a few bad days, that really sets them back. So what I tell these patients is, look, all you can do is do a few leg lifts, lying on the floor, lying in your bed, do some leg lifts, do some arm lifts, and that's all you need. So strengthening the muscles without stressing the joints is really key here. Start really, really very low and progress very slowly. So start low, really low, and then progress very slowly. One of the things is that if their tissue is very fragile, and if they push themselves, what happens is they sustain tissue damage, and then they take a very long time to heal, and that sets them back a lot more. I would avoid extreme stretching because one of the things that we don't want to do is stretch these muscles so much that they now make the joints unstable. Some degree of passive stretching is all right, but getting into extreme stretching exercises is not a good idea in this group of patients. Now, the other thing is that we need to keep their limbs within their extreme range of motion. So for example, the knee joint has a range of motion, say from 0 to 140 degrees. What I want them to do is stop short of getting to their extreme range. So instead of going all the way to 140 or extreme flexion, and I want them to stop at 130. Same thing, I don't want them to extend or hyperextend their knee and stop short over here. So for every joint, they need to stay within the range of motion and not go to the extremes of motion. Aquatic therapy is by far the best. One of course, the contact of water with the skin helps their proprioception. The other one is that it takes the load off the joints, so they are free to, and they can exercise more freely. But what I don't recommend is swimming, especially freestyle swimming. What that does is it makes the shoulder joints more unstable. It makes the neck joints more unstable. Breaststroke is okay. Swimming with a kickboard is all right, but definitely not freestyle swimming. The best exercise for these people is to actually walk in water, tread water. There's some really great exercises that can be done without stressing joints. This is a technique that was developed by a physicist, actually, Moshe Feldenkrais. It's called the Feldenkrais method. It's becoming much more popular now. It is a type of physical therapy that helps repair impaired connections between the brain and the body. So the idea is that when a part of the body hurts and if they develop chronic pain, then the brain sort of shuts it off. And so it's not adapting to it. It's not utilizing that part as much. And the Feldenkrais method actually repairs that connection. What happens is patients with EDS, and in fact patients with most chronic joint conditions like arthritis and all, they develop very inefficient and strained habitual movement patterns. If somebody has arthritis of the right knee or pain in the right knee, they start to compensate, and they put pressure on their left side, and their back hurts, and then their left hip hurts. So they develop these strained habitual movement patterns. What the Feldenkrais method does is it uses a very slow repetition to teach correct and safe movements to almost turns the clock back. These exercises are very gentle, very slow, and it's almost, you can actually, this is a picture where they're doing a Feldenkrais technique. You can see they're sitting and exercising. That is a website, the feldenkrais.com. You can actually plug in your zip code there, and it'll tell you who the local providers are. A little note on tendonitis and bursitis. These patients present an immense amount of tendonitis and bursitis. And this is, again, not limited to just Ehlers-Danlos syndrome. This is in general also. Let's look at why people develop tendonitis or bursitis. This picture over here is a normal joint. So you can see the two bones. That's the capsule over there. There's a muscle, and then that eventually becomes a tendon, and then that inserts into the bone here. Between the muscle and the tendon, between the muscle and tendon and the bone, there's a small pocket of fluid called a bursa. If this bone were to shift, if these bones were to shift in any way, what happens, or if there was any changes to the bone structure or to the joint itself, what happens is there's an undue pressure, force applied to the muscle and the tendon, and this bursa over here starts to get inflamed. The idea behind my saying this is that the problem is not the bursa itself. The bursitis is a result of something else that's going on. So the treatment would lie in the treatment in this case is to treat the underlying problem. Is it a unstable joint, bracing to align the joint? Is it correcting the posture? This, by the way, correcting the posture is one of the common causes of trochanteric bursitis. So especially when you're standing or joint loading, avoid a repetitive use of the joint. If these people are forming a bursitis because they have a bad, a hyperextended elbow joint or a damaged elbow joint, they will start to develop tendonitis and bursitis. This is a technique called neuromuscular taping. It's a very useful technique, again, not just in Ehlers-Danlos patients, but also in chronic pain patients. The neuromuscular tape, which was popularized as kinesiotape taping technique back in the Seoul Olympics, actually. This is an adhesive. It's placed in a fingerprint pattern. It's a very light adhesive. But it's also very firm. It stays on for 5 days. The tape will stay on for 5 days. You can shower, you can do anything with it, it'll stay on. The idea behind this fingerprint was to give the notion of a gentle stretch with your fingers. And that's what neuromuscular taping is, part of that is. It mimics the superficial layer of the skin, and after 10 minutes, actually, once the tape is put on, they don't feel it. The tape is stretchable. You can stretch it. It's porous, it dries easily, and like I said, the adhesive is in a wave-like pattern. General recommendations by manufacturers is to put it on for 5 days. In practice, I've noticed that it's better to do it for 3 days at a time and then change it. Now, in terms of Ehlers-Danlos patients, what the taping does is it stimulates the cutaneous mechanoreceptors, which then improves the proprioceptive inputs. And I suspect that this is a technique that's used this is a principle behind using neuromuscular taping in all of these chronic pain conditions, including Ehlers-Danlos. So what does neuromuscular taping do is it reduces pain, improves proprioception, it relaxes muscles, stabilizes joints, it supports weak joints, and it's amazing for reducing swelling. This was a paper that was published in 2015 in which they looked at this neuromuscular technique for knee joint pain in patients with Ehlers-Danlos syndromes. What they did record was an improvement was seen in the spatio-temporal parameters. Step length improved, and their cadence, the rhythm and velocity improved. Because patients with Ehlers-Danlos syndrome present with so many different areas of pain, and I think it's easier to just go by it region by region. I'm going to start from the head and go down to the feet. They do present commonly with headaches, and this is a small list of reasons for headaches. I've actually filtered out the more common ones. Migraines, cervicogenic headaches, they almost all of them have temporomandibular joint dysfunction that leads to facial and head pain. Chiari malformation is very common. They have blurry vision. They also have dysautonomia, also known as POTS, postural orthostatic tachycardia syndrome, tethered cord syndrome, spontaneous CSF leak, craniocervical instability, and idiopathic intracranial hypertension. I'll briefly touch on each one of these. But in 2017, there was a very nice paper published by a large group of neurosurgeons and neurologists. The citation is down here at the bottom. Idiopathic intracranial hypertension, also known as pseudotumor cerebri. Basically, these people have raised intracranial pressure. They present with visual disturbances, photophobia, tinnitus, and the idea again. There's the suspicion that they have narrowing of the blood flow, mostly a venous sinus stenosis. And of course, the standard treatment is to do a spinal tap, an eye exam, and an MR venography. Weight loss there's some data about weight loss in these patients may help this group. And then there are medicines to decrease the cerebrospinal fluid pressure, VP shunt, or a stent. The hypothesis is in this group of patients is that they're either producing excessive CSF or there's excessive fluid content in the brain, so the brain itself is swollen, or they have an increased cerebral venous pressure, which leads to reduced CSF reabsorption. Now, they may come back and say, my headache gets worse when I stand and it almost goes away when I lie down. This is really key. It almost goes away when I lie down. This is a classical symptom of spontaneous CSF leak. It is really difficult to pinpoint where the leak is or where the leaks are actually. We're not quite sure. These patients present with classical symptoms of CSF leak. And again, the diagnosis is based on their symptom of saying that the headache gets worse when they stand up, and literally it goes down to zero when they lie down. Temporomandibular joint dysfunction. This is the area of pain with patients with TMJ. Obviously, the pain starts in here, but it usually spreads the temporal region up into the frontal, the jaw, the neck, and all the way into the interscapular region. They'll present with neck pain. Of course, most of them will present with headaches. They'll tell you about clicking noises. Their partner will tell you whether they are clenching or grinding when they sleep, difficulty opening their mouth wide, and their jaw sometimes locks up, like subluxes, the temporomandibular joint itself, subluxes. Chiari malformation is very common in this group of patients. And just to refresh what Chiari malformation is, this over here is a pictorial of the normal brain, and you can see the cerebellum is in the posterior fossa. This is the foramen magnum. What happens in Chiari malformation is that the fossa is smaller, and it pushes the brainstem and the cerebellar tonsils through the foramen magnum into the spinal canal. So they present with symptoms of compression of cranial nerve roots, cerebellar compression, brainstem compression. And these are the symptoms. The ones in the red are the more common presentations. They have neck pain. They present with balance problems. Remember cerebellum. They have paresthesias to their arms and legs. They have dizziness, which is very common, difficulty swallowing, poor hand coordination, and classically they'll tell you about headaches that get worse with coughing or straining. This is a question that you have to actually ask pointedly, because oftentimes they don't quite recognize it or bring it up themselves. They may also present with tinnitus, hearing loss, nausea, vomiting. They may have, if there's a localized increase in pressure, then they might present with suboccipital headaches. So the question is, why is there a higher incidence of Chiari and EDS? We're not quite sure. Some of the theories are that there's a cranial settling. So when they when they're in a upright position, because they have loose joints, the cranium actually settles down on the cervical vertebra. There's more gliding of the posterior gliding on the condyles. These are the three angles that neurosurgeons often look for, the clivus axis angle, the clivus atlas angle, and the atlas axis angle. Oftentimes these are measured on radiological pictures. So how do you make a diagnosis of Chiari malformation? A patient coming in with the classical symptoms of Chiari malformation that I just talked about. So a good history and physical examination, and an upright MRI of the neck, and I'll explain to you why I insist on why it's a good idea to get an upright of the MRI of the neck. So the picture on the left is a picture in the supine position, and the picture on the right is the same patient in a sitting position. This line is called the clivoaxial angle. The clivoaxial angle normally is about 140 degrees. In the supine position, you can see the clivoaxial angle over here is 141 degrees. You can see the cerebellum is nicely placed in the posterior fossa. The brainstem is pretty nicely it's not protruding down into the foramen magnum. The same patient in the upright position, because of cranial settling, posterior gliding of the cranium, the clivoaxial angle has now become far more acute. It's now 133 degrees. You can see the cerebellum and the brainstem pushing down. So that is the reason why it's important to get an upright MRI in these patients. The recommendation is to ask when putting in a request for an MRI in the upright position. Radiologists, you may have to ask the radiologist to actually measure the clivoaxial angle. They do not do it on a routinely, but asking them specifically, requesting for it specifically would help. So moving down to the neck pain in EDS, they have muscle spasms. We know why they have muscle spasms. There's craniocervical instability. They have cervical disc degeneration. They actually develop disc degeneration early in life. It's more commonly at the C4, C5, and the C5, C6 levels. They have Chiari malformation. Now, the neck is primarily stabilized by ligaments. There's not a whole lot of muscles we have around the neck. At least we don't have major neck muscles, unlike the thoracic area or the lower back. So any laxity of these ligaments causes the joints to move around. Now, a typical head weighs about 10 to 12 pounds balanced on the neck. And if they start to protrude their head forward because of joint laxity, these patients start to present with there's an increase in the force. So if they stick their head forward by 2 inches, the pressure now becomes 32 pounds. So it's really critical in these patients is to maintain a good posture. Again, they also develop neck pain because it's an attempt to stabilize the neck. I've kind of divided it into upper cervical CO to C2, and then we have C3 to C7, CO being the cervical occipital joint. In the upper cervical region, any instability there, they present with neck pain, stiffness, headaches, dizziness, paresthesias to their face, fatigue, poor sleep is common, tinnitus, and then there's poor vision. These are some of the issues they present with. They also have difficulty swallowing. In the lower cervical vertebra, there are predominantly more peripheral features like muscle spasms around the neck. They have neck pain, and then they have paresthesias to their fingers. And this is again, it's really critical to differentiate this because this is a classical symptom of a patient presenting with disc degeneration. So are these symptoms from disc degeneration or are they from instability of the neck? It's really important to differentiate that. There's something called the Barry-Lou syndrome. The Barry-Lou syndrome, this is Barry from the famous neurologist from the Guillain-Barré syndrome, and one of the syndromes that is not as well known that he had talked about was the Barry-Lou syndrome. What happens is in this group of patients is that because of the craniocervical instability, remember the sympathetic chain is literally plastered onto the anterior aspect of the vertebra. And so any craniocervical instability, the theory is that any craniocervical instability over here may be affecting some of the sympathetic chain over here, the cervical sympathetic ganglion. And so these patients can present with symptoms of of course they have cervical instability. They present with difficulty swallowing. They have some autonomic features also, like blurred vision, ringing in their ears, dizziness, neck pain, of course, and headaches. The problem with getting imaging on craniocervical instability, is all pictures that we do, MRIs, CAT scans, X-rays, are all static pictures. So these are pictures taken at a point in time. But what we really need is a functional picture. What happens when they move their head or move their neck? So we need to have functional imaging. And some of the things that neurosurgeons who treat this condition often do ask for is a functional computerized tomography. They like to get pictures taken in flexion, rotate the neck to the left, rotate it to the right, and then they look at the translation of the vertebra in these cases. In craniocervical instability and also for patients with Chiari malformation, these are the three angles that surgeons like to look at, are the clivo-axial angle, the Harris measurement, and the Grad-Mapstone-Oak measurement. Some of the neurosurgeons do their own measurements, but not to put too much pressure on the neuroradiologist, I think it might be best to just ask for clivo-axial angle measurements in these patients, provided in an upright position. For the mild to moderate cases, neck strengthening exercises, a hard cervical collar is the way to go in these cases, because what we really want to do is stabilize their neck, and so it supports the mandible against the sternum and the clavicle. And of course, in severe cases, one has to consider surgical fusion. I really don't think soft neck collars do help. They really just don't provide the support needed. This group of patients also presents with tethered cord syndrome. The classical symptoms are low back pain. There's no outstanding reason for having low back pain. They have the symptoms of neurogenic bladder. They have weakness to their leg. They have sensory loss. They have musculoskeletal abnormalities. I'm going to refresh your memory on tethered cord. So we know that this picture is a normal spine. This is the tethered cord spine. And you can see over here, the conus ends at L1, and then the phylum sort of extends down, and then it hangs freely. In tethered cord, what happens is the phylum is tethered to the bottom of the spine here, often develops a fatty infiltration, and the conus is lower down. So the conus normally ends at L1, is now over here at L3. Patients, oftentimes, this is something that you see in patients in the younger group when they go through a growth spurt. So as they grow taller, the spinal cord gets stretched out because of the tethered cord. It's really difficult to figure this out on an MRI unless one is looking for fatty tissue infiltration. But an MRI is not a reliable diagnostic criteria for tethered cord syndrome. And so the neurosurgeons who treat this often do refer to it as occult tethered cord syndrome. The question is, how many patients with Chiari malformation and tethered cord how many patients with tethered cord present with Chiari malformation? And so this was a study that was presented by Melorat and Bolognese back in 2009, where they looked at patients who came in with tethered cord. 14% of them had a clear case of Chiari malformation. They met the criteria for Chiari malformation. And then they subdivided some of these patients into what they call as the low-lying cerebellar tonsils. These people didn't quite meet the criteria for Chiari malformation, but their cerebellar tonsils were low-lying, and that was 63%. So if you add up the two of them, it turns out to be about 77% of patients with EDS have Chiari symptoms as well as tethered cord. The reason for bringing up this slide was that if a patient comes in with Ehlers-Danlos syndrome, and if they get diagnosed with Chiari symptoms, look for tethered cord, or vice versa. If they present with symptoms of tethered cord, look for Chiari symptoms. They present with achy, burning pain in their back, legs. They have Charlie Horse-like pain in their calves, their weakness in their legs, tingling, decreased sensation in the perineum. They will have a history of toe walking or heel walking. This is an important feature in this patient. They have bladder symptoms, neurogenic bladder, urinary hesitancy, increased frequency. That's a mistype. They have urgency, sense of incomplete emptying of the bladder. More than urinary tract infections is not critical, but the more important one is sense of incomplete emptying of the bladder, and some of them even have incontinence. Again, MRI is not a useful study. The diagnosis is based on a good clinical history and examination and a urodynamic study by a urologist. So moving down to chest wall pain and EDS, believe it or not, a lot of these patients present with symptoms of costochondritis. When asked, they'll tell you that they have complaints of struggling and getting a breath in. They have pain from their ribs, and of course, we do have to rule out any cardiac or pulmonary causes. Each rib makes 3 joints in the back, and then there's the diaphragm, which is an important muscle of breathing, and each rib has 3 layers of muscles. So there's a lot of muscles and a lot of joints. This, again, when we inspire, the ribs move up, the diaphragm moves down. When we exhale, the ribs move down and the diaphragm moves up. So there's a lot of coordination. What happens in these patients is that they lose this coordination. There's loss of proprioception from the ribs. And they can often tell you that they have a sensation of not taking a full breath in. They wind up having rib subluxations. They wind up having spasms to their intercostal muscles, often presenting as costochondritis. And some of these muscles that they are used for breathing are also part of their lower back, which is the quadratus lumborum, the diaphragm, and the psoas. This is a very nice exercise they can do. They can lie supine, place a book on their belly button, and breathe in and breathe out, lifting the book 20 times twice a day. There are a few more that they can do, singing in high and low notes, playing a recorder. That again helps them in their symptoms of costochondritis and rib subluxation. So moving down to pain in the arms, shoulder and arms, there's again a laxity of the shoulder joint that causes the muscles around the rotator cuff to spasm. They also there's a very high incidence of thoracic outlet syndrome in this patient. Symptoms of thoracic outlet syndrome are classical symptoms of pain in the shoulder, maybe the neck, going down the arm. Just to recap the anatomy of the thoracic outlet syndrome, the brachial plexus winds through between the first rib and the clavicle, and as it goes down to the arm, you have the blood vessels, the arteries, and the veins. In these patients, this subluxation of the clavicle or the subluxation of the first rib, or muscle spasms over here, or the scalenus muscles or the pectoralis muscles can cause compression of either the vein, artery, or the nerve, and they present with classical symptoms of thoracic outlet syndrome. Hands and wrists, again, they tend to hold objects very tightly because they have poor proprioception. Because of poor proprioception, their brain doesn't quite figure out that they're holding something, so they tend to drop things easily. When they write, they hold a pen really. This is the way they often hold a pen. They wrap their fingers around it. They have poor haptic feedback. So when they're actually writing on paper, they get no feedback from it. So they tend to literally grind the pen into the paper, and you can see that. I'll have them write their name on a piece of paper in my office, and I can see them pushing the pen right through the paper. This abnormal pressure causes pain in the muscles of the hand and the small joints. And again, they have laxity there, so they also sublux these joints. So let's talk about splinting and braces in general. Braces maintain the joint in a neutral position. That's what a brace is supposed to do. It is supposed to prevent hyperextension. It also, the contact of the brace with the joint helps with proprioception. The trick is to start them gradually. Introduce them very slowly. What I tell them is use them once an hour a day for a week, then 2 hours a day for a week, and so on. The question is that plagued us is, do braces make our muscles weaker? And the answer is no, they do not. In fact, braces make them stronger. It's a very common misconception. No brace is tight enough to stop muscles from moving. And in fact, braces don't go around muscles. They go around joints. Braces, in fact, stabilize the joints, allowing the muscles to move more efficiently. So they actually help in strengthening muscles. I believe the misconception came from confusing it with plaster casting, where the muscle is in a cast. Legs and knees are moving down. In the legs and knees, the lower half of the body, I want to jump straight to the feet and ankles, because if the feet and ankles are unstable, then they make the knees unstable. And then if the knee is already unstable in a lot of these patients, which makes their hip unstable, which then throws their spine off. So in order to get this chain, to fix this chain, you have to work on the knees and the feet first. This is very common. They have flat feet. If you have them just stand in your office bare feet, you can see that straight line here instead of an arch. They have to be standing. If they lift up their foot, you can see a beautiful arch, but then it collapses the minute they put their weight on it. So this is a straight line you can see over here. You have them turn around and you'll see a little overpronation of the ankles. And as you can see, the force over here is definitely not passing through the heel. And this is often very common in unstable ankles and flat feet. There'll be a lot more details about discussion on dysautonomy and POTS, but I wanted to talk to you about it in relation to EDS. Dysautonomy is a dysfunction of the autonomic nervous system. These patients, what they do is they pool blood to their lower extremities, excessive blood to their lower extremities. In fact, if you have them stand for a minute, you'll see their feet turn dark and their hands turn dark. What happens is, as a compensation, their sympathetic nervous system triggers increased sympathetic activity. So they have a surge in their sympathetic outflow. And this delay, so what happens is there's a delay, their blood is pumped up, the heart then picks up, there's an amount of tachycardia that leads to palpitations. So they present with fainting, dizziness, palpitations, fatigue, headaches, cold hands and feet. Brain fog is very common, and there's a feeling of constant anxiety. Now remember, anxiety is a symptom, presents as increased sympathetic overactivity. So basically, these patients, their anxiety is not coming from their brain, it's coming more from their peripheral system, it's coming from their body. There's an increase in sympathetic overactivity here. Diagnosis, this is the clinical criteria for it. There's an increase in heart rate by 30 beats within 10 minutes of standing. And of course, if there's a absolute heartbeat of 120 beats within 10 minutes of standing, but there is no significant change in blood pressure. This is key. So there's no change in blood pressure. They have symptoms of syncope or almost syncope. In children, there's an increase in 40 beats per minute. I'm sorry. This is a really nice website. It's a non-profit organization called Dysautonomy International. This has a lot of resources for physicians and patients, and I'll oftentimes go there myself. There's lots of great literature out there, peer-reviewed literature, and there's lots of information for patients. The problem in EDS is that because of this constant state of dizziness and instability that they get from their dizziness, and they already have lax joints, their muscles tighten reflexly, and this causes their muscle pain to get worse and increases their fatigue. This is the test I do in my office to detect that. What I do is have them lie down supine for 5 minutes, and then I check their blood pressure and heart rate. And then I do one immediately after standing, and then You can do one after standing for 2 minutes, 5 minutes, and 10 minutes. Again, there's a change it is an increase in heart rate by 30 beats per minute. That is significant, but of course, with no change in blood pressure. This is what I was trying to explain to you, was the sense of anxiety in these patients. A lot of their anxiety, some of their anxiety is of course central, because these are patients who are having a difficult time. They have intense fatigue. They have a lot of pain. But the other is that they also, it's because of their dysautonomia, because of a malfunction of the autonomic nervous system. Mast cell activation syndrome is another, it's a newer cluster that we are starting to see. It has us all baffled. Again, you have wonderful speakers coming in talking about this. But basically, mast cell is an activation syndrome, is an immunological condition in which mast cells are inappropriately triggered and release chemical mediators. I want to differentiate this from mastocytosis, where there is an absolute increase in mast cells. Over here, there is no increase in mast cells, just that the mast cells are being inappropriately triggered. They present with symptoms of rashes, hives, fatigue, muscle pain, bone pain, abdominal pain, bloating, nausea. That's symptoms of gastroparesis or dysmotility. They have palpitations, presyncope. They have flushing after a hot shower. It almost feels like they have a constant feeling of having flu, which is what happens in flu is our mast cells are being triggered. These are some of the symptoms graphically presented, and you can see they have airway reactivity, they have skin symptoms, brain fog. So how do we put all this together? We talked about Ehlers-Danlos syndrome, we talked about POTS and mast cell activation syndrome, and you can see all of these three conditions can present with headaches, brain fog, dizziness. Which one of these is, they're all contributing to it, but one of them may be contributing more than the other. But the thing is, in order to get this under control, we have to treat all three of them. Blurry vision, racing heart, belly pain, weakness, dark discoloration of their feet. These are some of the symptoms of all three of these conditions. Fatigue is immense. These patients have a significant amount of fatigue. We're not quite sure what it is. One of the theories is that they have, of course, Ehlers-Danlos syndrome itself causes fatigue. There's a dysautonomia, mast cell activation syndrome, drugs to help them with sleep or pain. The pain itself causes fatigue. They have poor sleep. And then there's always a question of secondary mitochondrial dysfunction in this group of patients. Biopsies done on these patients, muscle biopsies done on these patients showed myopathy and axonal sensory motor polyneuropathy. So we know that the muscle itself is weak in these patients. Now, one of the things is that this is in black is the non-Ehlers-Danlos, and on the red is the EDS patients. Muscles in this patient, when they are relaxed at rest and contract with activity. But in EDS, the muscles are always tensed and constantly attempting to stabilize even at rest. The ligaments in non-EDS patients are tensed at rest. They support and stabilize the body while the muscles are relaxing. In this case, the ligaments provide no tension and stability, so the muscles have to work extra hard to stabilize these patients. A little bit about this. It is controversial, but I had to bring it up because medicinal marijuana has this group of patients they've surprised me in how well they respond to medicinal marijuana. They don't respond to opioid analgesics. They have many contraindications for taking NSAIDs, and they also have lots of contraindications for taking opioids. It worsens their mast cell activation syndrome. It sets up their gastroparesis. So briefly, the human body has two types of receptors, the CB1 and CB2. The CB1 is found in the brain. CB2 are found in the rest of the body, immune cells and the glial cells of the nervous system, so they're part of the immune system. Chemicals that cause inflammation in the peripheral parts of the body are modulated by cannabinoids. Hence, cannabis applied topically can be helpful in these patients. We have patients where it has helped them topically. It's something to look at if it is legal in your state. It's a reasonable choice to try. It helps them with their intense nausea. It helps them with their pain. The trick here is that, again, we don't have any specific studies of using medicinal marijuana in patients with EDS. But the trick is, again, using higher levels of CBD and lower levels of THC. THC is known to cause the cognitive effects. And you can actually reverse this at night because THC can help them sleep. It can be vaporized. It can be taken as edibles. It can be used topically. It's very helpful on tendons, ligaments, joints. And of course, they don't affect mast cell activation syndrome as much as NSAIDs and opioids do. So again, connecting the dots, these patients present with symptoms of fatigue that can be from all of these three conditions, diffuse pain from all of these conditions, headaches can be from EDS, POTS, mast cell, tethered cord, Chiari malformation, joint pain can be also from tethered cord, EDS, dizziness, again, POTS and Chiari malformation can do that, poor balance from all of these conditions. So these patients present with multiple issues and multiple conditions, and it's really a question of just connecting the dots. And I think the best approach would be to first get the correct diagnosis, which was presented earlier. So getting the correct diagnosis is a really easy diagnosis to make. And then once the diagnosis is made, and then it's a question of, okay, what is it that's acting up the most? What do they need their most help from? Is it the subluxations? Is it the POTS? Is it the mast cell? And then going after that one at a time. Thank you. And with this, I can end my presentation. I'll be happy to answer any questions. That's my email address. Feel free to email me with any questions.